Good morning. We're going to get started. Thank you for coming today on this Friday morning. So today we're going to talk about how to build an emergency medicine research program, hopefully give some tips. We have a nice top 10 countdown. And I'm Sara Heinert from Rutgers Robert Wood Johnson Medical School. These are all our contributors that couldn't fit on the stage, so they will be down there and over there with a microphone. And we'll do introductions in just a minute. These are our disclosure for one of our. And so today we're going to be talking about best practices for developing an EM research program. We're going to give some tips, tricks, and pitfalls from research directors across the country, and we're going to cite some common obstacles for programs and how to overcome them, and also how to involve med students, residents, and faculty in research. We're going to start with introductions. We're going to talk about what is a research director / vice chair of research, and we're going to talk about our top 10 considerations when building an EM research program. And then we'll take questions at the end. So hopefully we'll have some time for a nice discussion. These are our top 10 considerations, and so we'll go through each of them individually and provide some details on each. So now for introductions, start with Kiran.
Really brief because we have a fair number of us. My name is Kiran Faryar. I am the Director of Research at University Hospitals Cleveland Medical Center. I personally do a lot of research in public health and health services. I was brought on to UH about 3 years ago as kind of one of the in this kind of new role. They really didn't have like a formal research director before then. And we'll get into some of the details, but my chair basically said just fix research. Like that was my job description. I was given very little guidance on how to do that, very little metrics. So definitely kind of building the plane as I flied it. And we'll get into, again, kind of talking more details, but I'm excited to be here.
Hey everyone, I'm Mike Gottlieb. I'm Vice Chair of Research at Rush. I'm also a research fixer, which probably should be an actual official title in there because it's a different role. I came into an institution that also traditionally didn't do a lot of research and specifically didn't do a lot of funded research. Didn't have a lot of infrastructure, in fact had almost none. And I got my first grant and I looked around like, oh, I don't have anyone to help me get any of this stuff sorted out and to figure all this out. And we built our program now over the past several years, and I took over as formally as Vice Chair of Research this past year. And so I'm excited to kind of share some of the pros, pitfalls, strategies as we go through this for funded and unfunded, and to learn from some of my colleagues as well.
I'll just be up here. You could give that to Jaime. Hi, I'm Sara again. So I have been a research director at Robert Wood Johnson in New Jersey for almost 4 years. Prior to that, I was a research director at University of Illinois at Chicago for 7. And I think I'm our lone PhD. So my background is in public health. And I was really brought in as someone who could devote my time to research. And so I think that's been very helpful for the departments that I've worked with, the institutions that I've worked with, in terms of having someone who is completely dedicated to research. So.
Hi everybody, I'm Jaime Jordan. I am not a research director and I'm not a research fixer, so that is not my role and I don't really belong up here with this illustrious group. But I am an education researcher and I am an associate program director, and I do direct our discovery year for the medical school, which is really a year focused on scholarship. So I am here more to give the perspective about engaging our learners in research.
Hi everyone, my name is Roz King. I'm the Director of Research for the University of Vermont, and unlike Mike and Kiran, I wasn't called in to fix research, I was called in to say, can you make some happen? We had one research faculty who's an outstanding researcher, but we're a newer department, and so everyone else was like, not super into it, and I'm really excited to say that we've changed that, and it's continuing to grow, but it's a long process.
Hi, James Paxton, Wayne State University in Detroit, Michigan. I'm the Director of Clinical Research at Detroit Receiving Hospital. It's one of our constituent hospitals there. And have been fortunate to see lots of successful grant applications and research studies, but also lots of failed ones. And so I think you learn a lot from your mistakes and from other people's mistakes. And I think sessions like this are going to be a great chance to share some of those lessons. So, Erin.
Hi there, I'm Erin Simon. I am Research Director at Cleveland Clinic Akron General, and I've been in this position for about 10 years. I was pretty new out of residency when I began my role as Research Director, and it was one of those things where our previous Research Director got promoted to a more administrative role as a CMO, and they were just like, here you go. And there was a lot of growth that needed to happen. Our residents weren't really engaged, and our scholarly activity requirements were pretty minimal. And I really had very limited infrastructure to build this with, but we've grown tremendously over the past 10 years, and our faculty are much more engaged, our residents are much more engaged. We've built like a focus around also our students and engaging them in research as well, which has been a good recruiting tool. So I'm happy to share some of the tips I've learned over the last decade.
Okay, so now we're gonna go through some numbers. This is the only part of our slides with all these numbers. So the Research Director Interest Group completed a survey with research directors and vice chairs of research a year ago at SAEM and through the SAEM listservs. And so this goes through a little bit in terms of who is a research director and what are their roles. So I should also say we had 29 people complete it, so take this with a grain of salt. But of those who completed it, this is what we got. So what? Yeah, right, yeah. Mm-hmm. That is funny. Okay, so the majority were female, 59%, and the majority were white and non-Hispanic. So in terms of credentials, the majority had a clinical degree, MD, DO. Most had a master's degree, and then some had PhDs, either only a PhD or a PhD as well. So this was a select all that apply, and one was a RN. We also asked about research training. Again, this was select all that apply, and so the most common research training was a master's degree, followed by research fellowship, and then career development programs or awards, including K awards. We also asked about roles and responsibilities, and the most common response for that was collaboration with researchers, followed by my own grants. Resident research was a big one as well, and faculty research, and then mentorship of faculty and mentorship of trainees. So a lot of mentorship, a lot of research, and working with both the faculty and the residents on that. We also wanted to know who assisted the research director, and this varied pretty widely. The most common for administrative assistants that research directors or vice chairs of research had was a research coordinator, followed by biostatistician, but 5% of people had none of these, so had no administrative assistants at all. We also asked how many FTEs, how many FTEs, non-faculty research support staff, do you have? 29% had none, and then the rest of the people had more. The most common response here was 1 to 3. So and 21% had 9 or more. So there's a lot of variety, a lot of differences between the different programs. Some have a lot of infrastructure, and some have none to very small. We also asked about how a research director is supported, and asked specifically, is your position supported by a direct stipend? 45% said yes. Is your position supported by hours buy down? 79% said yes for that one. And then how much effort do you have for your research director position? 68% had less than 0.25. whereas 8% had greater than 0.5. And how is your research director role currently funded? Most people said it was funded by the department, the med school, or the university. Okay.
So, yeah, thanks. So we're going to talk a little bit about some specific issues that maybe some of you in the audience have faced. I think some of us up here have definitely faced some things here. And one of the things I think that you have to start with when evaluating the likelihood of success at establishing a research program or improving a research program is buy-in and support from those above you. I'm going to pick on my chair. Okay, that's not my chair, but you know, some people have difficult bosses to work with, but mine is great. Nothing like other people that we can think of. But at the end of the day, it isn't necessarily a problem that you come into a position with a different perspective than your boss or the people who have the money, right? The problem is if you don't recognize that there's dissonance there, you don't recognize that the expectations are not realistic. You have to decide, first of all, what kind of department you want to have, what kind of research mission you want to have, right? And there are a lot of times when you look at programs that are having issues and problems, there's a real disconnect between what they think they want to do and the resources that they have available to them. And I think one of the resources is leadership. So establishing that you have the same idea and vision for the department is important. Not only do you have to finance yourself and make sure that your time is paid for, but you've got to finance the operations of the department, of the research mission, right? And so you really need not only financial, but also sometimes emotional and moral support from your chair and other people above you. Make sure that you have the culture in place that you want to have. I think that's an important aspect here. I'm sure we're going to talk more about having a research culture or a culture that appreciates academic activity and scholarly activity. I think that in my department, we kind of vacillate, we kind of go back and forth between a more clinical bend and a more academic bend, right? And we certainly have members of our faculty who value the clinical side a lot more than the research side. But I think part of the support that you need from the chair is support in kind of improving the culture, maybe. Trying to have some of your clinical team members think a little more academically and support your mission and support you in what you're trying to do. Sometimes you're going to have projects that are going to come across the desk that just are not fundable, like there's no mechanism there, no one's going to pay for this, but maybe the faculty member really believes strongly in it, and this is a project that's going to really, hopefully, motivate that faculty member to do more work later on. And I think it's important to look for resources that you can use to leverage to get those projects funded. Hopefully they're small funding needs, but nonetheless, I think it's important to have resources and backup for that. Research imperatives should be top down. I don't think it's fair to ask, certainly not a junior faculty member, but even a senior faculty member to press the importance of research. It really should come from the chair and someone on the highest levels. And you want to have frequent meetings with your leadership team to discuss your goals, because goals are going to change. Some of you out there might be in departments that are really large research engines and you've got tons of grant money coming in. Some of you may not be in those situations, right? But as you grow, as you progress, as things improve, and as you get grants and as you get projects done and get projects started, your goals are going to change, right? So you're going to have not just long-term but short-term goals, and you're going to have discussions about those frequently. And I think it's important to recognize the things that motivate people and the things that perhaps disincentivize people to do what you want them to do. Sometimes it's just as simple as understanding the people you work with and the people that work under you, perhaps as a director. And what are the things that motivate them? What are the things that they're interested in, right? And I think we don't always talk about the human factors and really getting to know people. Sometimes we talk about numbers and goals, leadership from the top, et cetera, like that. But it's important to understand on the individual level what the people you're working with are going to be motivated by and what things that they might be disincentivized by. So we'll probably talk about some examples of that. And we're going to hand it off Now to Erin, who's going to talk about engagement.
So engaging your faculty is really important, just as getting your chair to help support that initiative is as well. So really you want to take the time to individually get to know your faculty, especially the ones that do have a genuine interest in research. Obviously we can't force people to do this. They have to want to do it. And you want to make sure that you're choosing projects that they feel are the right fit for them. Because if you try to put them in a box or try to assign them something that they're not passionate about, it's going to be really difficult for them to move forward. It's also important to find out what other things they're already doing within the hospital, right? So maybe they sit on a committee and there's things within that committee that they're doing work for or quality improvement projects. And those can be stepping stones for them to lead into research. Teamwork is really important. So I come from a program that has a limited infrastructure, so I don't have a lot of grant funding. We do find ways to find money, but I don't have grant writers and I don't have clinical nurses to enroll patients in prospective studies. So I'm working with different resources than maybe some of these much bigger programs are. So one of the ways that I've helped grow our program is we created a year-round medical student rotation. And those students can help with things. They can help with learning how to write IRB protocols and doing literature searches and things to kind of progress and move things forward. They can help with data cleaning, things along those lines. Our residents, we've also increased from when I took over what their scholarly activity requirements are. So they are not now all required to do a formal research project. And that's helpful too. Then you pair them up with other faculty that have similar interests, and that helps propel and move those projects forward. We also run a summer research fellowship, which is helpful too, because then you get those students for 2 solid months. And you can move things along at a much better rate when you have them committed to that time for 40 hours a week. And then it's really important to promote this. So you should be talking about the things that your faculty are doing and giving updates. So if you have monthly faculty meetings, you should be doing it that way. Our secretary is really great. Every time we have a publication, we get the link to the full text article for those first couple of months. And so I send that to her, and she does this nice, just quick, easy one-pager, highlights the people that are on the publication and puts the link in so people can go in and read it. And we've had a lot of great feedback with that. And also lets faculty know what you're doing, what you're utilizing your time for, and the successes that you're having, which is important.
All right, we talked a little bit about the importance of culture, right? And I think this means that we really want research to be pervasive. We want it to be accessible to everyone, not just a select few, and this includes our learners. I think, unfortunately, a lot of our trainees just don't have the basic foundation and knowledge and skills to be able to do this. And so I think that's one area where we can intervene, is really just creating some education. And this could be through a research seminar series. This could be incorporating research topics into your regular didactics. But giving them that basic foundation and skills can really be helpful. I think another opportunity that we can do is remembering to invite our learners to our department research meetings, right? This will be an opportunity for them to not only learn from seasoned researchers and really get that perspective, but they can also be invited to pitch their ideas and really gain some valuable feedback. You might even consider making this a mandatory experience for your learners, for your trainees, your residents, and your students, just to really ensure that everybody gets this type of exposure. All right, I think the other area where we can have some impact is really creating opportunities, right? So we can think and make it our goal that as faculty, all of our projects should involve at least one trainee, right? And really publicizing the work that we're doing. So making the central repository of all the research work that could use some trainee assistance, or maybe frequently emailing out opportunities. All right, this would be a nice way to really involve our learners. I think the other thing to keep in mind is, right, residents are busy, they're really tired. Anything that we can do to lower the activation energy for them to get involved can be really helpful. So this might mean actively pulling into them to projects. This might mean if they're doing the IRB, give them an example from a prior study that you did that they can cut and paste and tweak and then submit. Right? Really being clear about laying out the framework and then mentoring them closely so that they're not really left on their own to sort of figure some of these things out.
So I'm going to talk to you a little bit about how to build out your team. And so one of the things that I think a few of us have at our programs is a research associate program. So where I am, we offer a series of 4 courses under the College of Medicine. We teach undergraduates and postbacks, and it creates this really nice symbiotic relationship where we give them the foundation they need with research ethics and study design and a little bit about emergency medicine, and then we invite them into our department, and they become this workforce that screens and enrolls for active studies. It's really exciting for them. They get the clinical exposure. We even offer a minor now in emergency medicine where we are, and our courses are part of that. But it allows us to take on other studies that we wouldn't be able to otherwise. So we wouldn't be able to offer 24-hour coverage of our emergency department for studies. It means we can write that into other grants that make us somewhat more competitive. But it also, probably more importantly, allows us to take on those passion projects. Like, I just really care about this. I don't have any money, but I have a panel of people who really want to please us and do the work, and here they are ready to do it. So that's been really key. And then members of that program become somewhat of a feeder program into our paid positions. And so we're fortunate where we are to have a number of research coordinators and project managers, and I know not everyone does. If you're lucky, you might have some departmental funding, especially at the beginning, just to jumpstart your research efforts. But without that, always a good idea to write research coordinators into any grant opportunity that you can. I would caution you, and I think a lot of us on the panel had this experience, where you take free help. You have that really motivated pre-med student or undergrad, and you take them on because you don't have any money and you really want them to help you. And then even though they're well-intentioned, that first beach day, or in our case, snow day, or biochem exam, and they're not there. And that kind of inconsistency can really break a project. So although tempting, I would caution you against it, or maybe only limited amounts. Another way to get past that with a lack of funding is use the educational resource if you have it. So you might be able to offer tuition credit for them to come on for the summer to do some research credits with you. I just wanted to keep touching on the team there for just 1 second. So some other resources that can be really helpful are the ability to have a statistician on staff. So again, in a dream world with our infinite budget, we would pay a statistician to do the work so we don't have to do that terrible math that maybe no one likes to do. We're fortunate enough to have a portion of FTE for a statistician. If you don't, there are other options, like maybe working with some of the PhD programs in your area. They may have students that are willing to offer their services and help collaborate on a project. Another really great resource, if you can have it, is a grants manager. We have limited attention spans in emergency medicine. By the time we're done with specific aims and designing our project, we have no effort left for the institutional red tape that exists with submitting it through the internal process and continuations. And so if you have someone that you can help provide those services, that's a huge lift that's alleviated for your program. Again, knowing that money is no object, you can look into cost sharing these resources. So we could not support a full FTE of a statistician or a grants manager, but we share those efforts with our anesthesia department. So there are maybe ways to get around sharing those resources. And then when it comes to culture change, change is hard. It's really hard. And it's hard to get buy-in. And I think the most important avenue to get buy-in under is with your clinical staff. So staff can really make or break some of your research projects, especially when you're enrolling straight out of the emergency department. Every ED is different, but we all have that negative Nancy, right? We know who they are, the person that's going to flunk your idea, and it's always a night charge nurse who speaks loud and is called Mike, Matt, or Amanda, like every ED. I don't know why. You need to find that person and make them like you. And so you want to encourage them, whether it's like, hey, can you give me some feedback on this idea? I really trust your opinion. Let me know what you think. Or making them a champion for your project. That's going to go a really long way for you. That's part of that starting with the impossible. You know, you think they're unreachable. They're the person that's going to flunk you, and you want to make them your friend. And then it says here, share good news, but I would say just share any news. So at the beginning, we were sharing when we got a grant and when we got a publication, and much like you said, we were sharing it with the group, and they loved that. But sometimes we were going down there, and they're like, hey, you came in hot and heavy 6 months ago and said, you really need my help. We've been drawing blood on all your trauma patients with this study that you're doing. And then we never heard anything. You just ghosted us, and now you're back again. And that's fair. So you want to say to them, hey, you know, thanks to your help, we've recruited 80% of our target population. These are the results we're seeing so far. Like, let's keep up the good work together. And that team approach is really what's going to help create a lot of buy-in. Also finding out what they care about. So like, we have our own research passions. We come with our idea, and we hope they come along for the ride. But if you can find something they care about, that's going to go a long way too. So back in think it was 2014, 2013, we had a nurse who read something about about intranasal midazolam for NG tubes. And she was like, I really want to try this, it's amazing. Everyone hates inserting an NG tube. Can we do this? And we were actually able to stand up a randomized control trial that did it. It was really effective. It became standard of practice. We published on it. The nurse was on the publication. And it really reframed research as this like nagging additional task for our clinical team, for our staff, that then became something that they could be a part of and participate in and really see their role in advancing science. And I think that's key to any program advancement.
So, thanks, Roz. So I think I started talking about the chair and about funding and unfundable projects, and I think, it's sometimes hard to know what is a fundable project, right, until you've tried. But I think it's important to recognize that not every department wants to or needs to be full of NIH-funded researchers, right? When I sit in on meetings, I'm pretty active with the research committee and some other committees in the organization, and we talk a lot about funding, and we usually talk about NIH funding. That's usually where we're talking about. Lots of other things out there, lots of other organizations that are funding research, and that's just talking about external funding. You might have internal funding in your department. So I think it's a challenge for people who are trying to build a research program to really talk honestly about what they're doing when everybody's talking about NIH funding and you're still not there, right? So I think it's important to recognize that most departments don't start out with that, right? Most departments start out with very small projects, probably unfunded projects initially, and then they start reaching into perhaps smaller funding sources, and I think SAEM Foundation is a great example, a place where you can find a funding mechanism for your project. Most really good programs that I know that have a really large research engine and a really good operation, they don't give up those smaller mechanisms. They keep looking for those too, right? Because you're always going to have junior investigators, younger people starting. You don't want to get overly focused, I think, on things like NIH funding. You want to have a diversified portfolio, right? Because that is not the right mechanism for someone who's just getting started. So you need to be able to accommodate and be looking for opportunities outside of those really large $1 million grants, right? So I think it's important to understand, recognize, and enforce the idea among your faculty and your whole research team that unfunded projects lead to funded projects lead to really big funded projects. All of them are important, and you can't get too overly focused or obsessed on any one of those. I think having diversified portfolios are important. Understanding what it is within your institution that might represent a funding mechanism is important. And it's surprising sometimes talking to people who really have never explored the idea of an internal grant. And they may have money somewhere in their university or their institution that they're just not aware of. So I think it's important to look for those and not overlook the idea of nonprofit organizations and funding from those, because a lot of people do, honestly. And so when you go and you find these mechanisms, you realize that they're not as competitive as you thought they were because most people are focused elsewhere. I think in my department that we try to encourage people just to submit a grant of some sort, an application of some sort. And we don't really, obviously we have to put resources, allocate resources according to the size of the grant, right? Because we have to pay our salaries for our people. But we always have to constantly remind ourselves that the small grants are important too, and that there are mechanisms out there for most projects. So it's a question of how hard are you going to look, where are you going to look? Are you going to go right back to the same place you went to before, or are you going to explore and look around and find some other opportunities? So I think it's important to lift every rock, look for those opportunities that maybe other people aren't looking for. And that could be your advantage here. You know, even if you're in a small department, you might find the mechanism that fits for your project. So, yeah, and then I'll hand it off to Mike.
So research is a team sport, right? We get that research isn't built on a single person. You can have one single NIH funder, and if that's one single NIH funded person in your department, if that's all you have, it's not going to be enough to carry a department. You need to build it out. But especially as we're building out a team in this capacity, we're trying to build out a research infrastructure, it's collaboration. It's thinking through who you can collaborate to help build it. Whether it be unfunded research, and that was where I started a lot of my things, is I found a lot of people who were willing to do free research with me. And it was great, and we kind of built out teams, we built out some of this preliminary knowledge, we built a track record, and we could do that. It's figuring out funding and saying, all right, I'm in a new role, new institution, we're building something out. How do I navigate this? And yeah, we could bat our head against the wall for a very long time and eventually maybe find a solution to it. Or we could ask some of our colleagues who have been more funded in other departments, other institutions, figure out how they handle these situations. And so that's one thing, is I think just remembering that there's a lot of people who are going through similar things. I mean, all of us have gone through this in various capacities. That's why we're up here talking about some of this. But thinking around the other people at your institution, thinking about other people at other institutions who are going through this. And also where you can start to kind of build the fledgling support. Not everyone's going to come out the gate and get an RO1 for their department. So how do you start to build support to get the CRCs that will allow you to get the preliminary data to do the smaller projects, the smaller funding gets the bigger funding? And that's where you can start to identify, wait, you know what, I could be a co-investigator. Our site actually has for example, we could say, our site is a level 1 trauma center and we have, 40,000 trauma activations a year. You're looking for trauma activations, you're doing a study and you just don't have enough cases of trauma, positive fast scans, or you don't have enough cases that meet this criteria, we'll enroll for you. We'll fund that CRC, we'll build that kind of infrastructure. We now have someone that will be on an NIH grant so they're more competitive when they go after things. Or we can use this to help start to build the infrastructure to trial these things out. So I think just thinking in terms of how you can collaborate with other institutions, remembering that is a great, great resource to start to learn processes, to build this infrastructure, to build a track record of funding in successful studies. And also we think about our teams, think about beyond physicians. We tend to sometimes group into like, okay, let me ask the other docs in my department. But a lot of my teams, they include nurses, they include pharmacists, they include advanced practice, physician assistants, nurse practitioners. We have broader teams, tapping our PhD colleagues and who can bring different lenses to this. I think we need to think beyond that. We need to think about other specialties too. A lot of my research at collaborative infectious disease doctors, our biggest grant we have right now is myself and an ID doctor. And neither of us, I think, could have done it. It was a long COVID study. And so I don't think neither of us probably could have done this study in isolation because you needed both lenses of this. And so remembering that we have these colleagues across the institution and we should be tapping them, particularly early on, take advantage of this, reach out and say, hey, we're building out this program. What research would you do? Oh, look, you're looking to recruit patients. Guess where all the patients come in? From my house, from my ED. This is where they come from. Why not figure out how we can collaborate on this? How have you been successful in this? How do we elaborate on this? How do we help you to be successful and help ourselves be successful at the same time? Within your teams as well, figure out what people do well. If you have a person who's interested in education, they're not really that interested in research, or they're just all strong, they're like, I want to do teaching side, but I don't want to do that. Figure out how you can tap their knowledge. They could be the educator of your study, of your project. They could be the person that brings that, and you pair them up with someone who wants to do research, and you combine the skill sets. Rather than asking one person to be this panacea of all things, you can tap their expertise, and then maybe, they get a taste of research, like, oh, that's really cool, and they start to become an education researcher or an ultrasound researcher or in another area where they start in one area and they shift over. And so figure out where you can tap people's skills. And the last thing is, pairing off a lot of comments that have come across here is, especially as you're kind of managing your team, managing your department, check in with where people are. Figure out where people are stalling, figure out where the barriers are, tailor your department to the actual, not the generic barriers that everyone's facing, but where's your challenge? Maybe your challenge is you need a statistician on staff that does all that. But maybe it turns out that everyone thinks they need a statistician, and then when you hire one, they use them for 4 hours a month. And you're like, no, that really wasn't the barrier after all. It was a methodology, or the barrier was that we didn't have enough good ideas. Maybe everyone wants, I want our clinical research coordinators 24/7, and I want 2 of them. But you don't have enough studies that you're actually going to do anything beyond business hours. It's not a good use of your money, your time. So figure out where these are, tailor the response to what you actually need, and use your money wisely, and you'll be much more successful.
Hi. So dissemination is really important too. Dissemination is important, you always hear it. You need to disseminate things, abstracts, manuscripts for promotion to add to your CV, but also you really want to let others know that your program does research and you do research, and that really helps with the collaboration that Mike was talking about. If you want to collaborate with other departments in your institution, or if you want to collaborate with other emergency medicine departments in other institutions. You want to put that work out there so that they know that they can contact you and that you have some expertise in this and that you have interested people, interested faculty members who are in this field. So it's important to put yourself out there through dissemination. Abstracts and conferences are obviously important both in emergency medicine and then thinking through what other fields might be interested in the work that you're doing in emergency medicine. And journals, of course, too. So there are some tools to help find journals. There's this Jane website that you can put your abstract into the search thing and it will give you some possible good matches for the work that you've done. So finding journals that are interested in the type of research that you have done, looking at the mission of the journal, making sure it's a good fit before you submit to the journal, and then thinking about types of journal articles. So a lot of people think of a full research manuscript to submit, but there's a lot of other different types of journal articles that you can look into in a journal that are shorter, like a brief report or a commentary or, all sorts of things. So looking at the different types of articles that a journal accepts is really important because getting your work out there in whatever capacity makes sense is good. And so there might be kind of a brief report or something that you can do before a full research article. Also letting people know in the department, I'm a PhD, so I'm used to rejection because I have done research, but that's kind of a shift for a lot of clinicians, understanding that there is a lot of rejection in research. There is a lot of rejection from journals, from conference abstracts, for grants. And so getting people used to that mindset of, you will have to persevere to get this funded or to get this accepted by a journal and out there, I think is a little bit of a shift for a lot of people. And also just telling them too that revise and resubmit for a journal article is a good thing and you should do it. And they don't hate your article, they actually like your article and you just have to make these changes and they will probably accept your article. So just little things like that, just kind of starting from the basics for a lot of clinicians, it might be new to them, so. And then Kiran.
Okay, so we've talked a lot about some of these topics. I'll actually give some examples because I think the devil is in the details, right? So motivation, we've talked about motivating residents, faculty. So I've actually utilized the divisions within our department. So we have the ultrasound division, we have the toxicology, addiction medicine division. So they meet regularly. I attended those meetings and I said, at the either beginning or end, what kind of scholarship are you guys doing? What are you thinking about? I made it essentially an agenda item on their regular division meetings, just piggybacking off of what they already do when they already meet. And it was kind of crickets the first couple, but then they started thinking about projects and working as a division. If they have 3 faculty member, multiple residents, all of my residents sleep with like an ultrasound under their pillow. Just thinking like you can bring in so many different levels, and then you can bring the whole division up as a whole, right? So like if they have a couple ideas, one faculty member will champion this one, another will champion this one, but then they can all contribute to the manuscript, they can all be authors on it, and now the division has 3, 4 publications when they potentially had 0. So the career development portion, again, very much comes from the chair level. We have kind of we had a faculty meeting a couple months ago where we talked about kind of restructuring, and I threw out the idea of should we add as a small component of things like incentive pay, or if you have like an educational RVU type of situation, you as a faculty member have to be an author, first, middle, last, does not matter, on at least something once in 3 years. It's a low bar, but it's a bar, right? Like we have set a bar, we can always go up from there, but we've set a bar saying this is something that we as an academic institution, as faculty at academic institution with learners, want to at least strive for, and then go from there. So it's kind of like carrot to whip, and then again, money is associated with it, right? It's with the incentive pay, it's with their educational RVUs. So, do with that as you will. We have kind of other designations. Are you core versus non-core faculty? You can kind of slice and dice this various different ways. Again, talk to your chair about that. And then we've talked a lot about celebrating success, whether it be emailing out those articles. I have also made sure I am a standing agenda item on the faculty meetings. I take 5-10 minutes. If I have nothing new to say, then I'll highlight a project that month. Like, hey, this resident and faculty member did this great chart review project. And, again, showing people like what you're doing so they know that we are doing research and this is a breadth of what we're doing. Thank you. And then learning from your mistakes. I'm pretty transparent about the number of grants that I've submitted and not gotten funded. I literally made a table. One column is everything I submitted and didn't get funded, and one table is a lot shorter. It's the things I have submitted and that did get funded. And I share that openly with the faculty. I mean, again, we all know that's the nature of the job. It's a 2-to-1, 3-to-1 ratio, and that's fine. It's just the facts of life. What? 4-to-1.
If you're lucky.
Okay, all right. Yes, the columns are definitely disproportional. And then again, fostering those open discussions, being an agenda item so you can talk about, those are the things that I learned, things about timelines, both internally and then also having those discussions externally. I mean, we know emergency medicine's a young specialty. We're just now getting into research. Cardiology, oncology, they figured this stuff out decades ago. So talk with them, right? They have some of these lessons. Other things that I just was it's not on the mistakes specifically, but other things that are kind of small and silly that I've done that really have helped get research fostered and help to kind of spoon feed to our residents and faculty are things like making templates. So I made like a cover letter template for a publication because nobody, one, knew what that was, two, that they needed it. And so it was just very simple. I just kind of put in brackets like insert this here, or I just kind of made a template of a chair letter of support letter and just kind of put in brackets like, this is where you talk about yourself. This is where you talk about your experience, things like that. So they're not starting from a blank sheet of paper. If they write the abstract, I'll put those like just few lines into a manuscript template. And I say, look, you've already done a fair amount of this work. You just need to fill in the blanks. Because again, staring at a blank piece of paper when you're trying to write a manuscript is very daunting. But you can kind of show them either taking from their IRB protocol or their abstract, you're 40% of the way there. You just have to fill in the rest of the sections. And I think that really helps. Roz gave a great example of a nurse who had was really irked by the NG insertion process, like most of them are. We have a specific faculty member who hates the urine drug screen. She mentions it she's a toxicologist, she mentions it in every single presentation. Everybody, all the faculty, or all the residents know that's her thing, and she just hates it. So I have helped to turn her rant into an actual chart review project. I said, let's put some evidence behind this and let's verify and validate your rant. And she felt very vindicated at the end of that. So yes, know your faculty, know what they like, know what they dislike, know what their skills are, and find things that kind of match their interests.
So we have 5 minutes left. So I'm just wondering if anyone has any questions that we can help answer. I wanted to leave a little time for that. If you do, yes.
Thank you. I'm sorry, I don't remember your name. The Research Associate Program. If you could just elaborate a little more on the details of that, because we love to use free labor through medical students, and exactly what you described happens. They get busy, they fall off, they ghost us. So what are the incentives of the Research Associate Program, and how do you get them to hang on?
Yeah, oh boy, I'm really proud of our Research Associate Program. So I could talk for a long time, and I'll try and make it brief. We offer 4 courses, and they're consecutive. They can take them in order. And so the first one is for 4 credits, and we offer instruction in the classroom for the 3 credits. And it covers really everything. We have a lecture, like I said, on research ethics, on study design. We bring in content experts for each of the lectures, made up of our residents, our own faculty, and guest faculty. And then there's a lab component. And so for that 1 credit, and that's what really draws, I would like to think it's my amazing, charming lecture style. And it is, but it's also that they get to shadow in the emergency department for part of that lab. So for some of the lab, we have a lab in our emergency department in the clinical space. We bring them in there, and we let them actually play with expired blood, and they try pipetting and aliquoting, and that's super exciting because they're touching something gross. And then for the rest of the time, they do shadow experiences with our nurses, our techs, and our physicians. And they absolutely love it, and it fills our cup. Like, for me to read their journals, and I'm like, I've had a terrible day clinically or academically, and then they're like, it was so cool, I got to see 3 EKGs, and then the doctor used this machine to talk into that, and you're like, wow, I remember being that excited about medicine, and that's like really refreshing. And so it's really, I mean it when it's symbiotic, like it's a beautiful collaboration. That's just getting them interested, and then they can go on and become that workforce. And so when they go into the second semester, they apply. We only take the best students, but they're mostly motivated pre-meds, so they're all great. And they come in and they do research associate shifts. And so they screen and enroll. We do 3.5-hour shifts. They get trained on all of our studies, and then they screen and enroll for our active studies. Alongside that, we offer this novel experience where they're broken up into small groups, and they take what they learn in the first semester and they compete for a hypothetical grant. And so they work with one of our faculty that they select to be their PI, and then they present at the end of the semester to a grant board. And so that's really exciting for them too. It gets them to interact more with faculty, which is really what they're looking for. And then they can continue on to be chiefs. And then they still attend those shifts in the subsequent semesters, and they continue screening, enrolling, and then helping to train the junior students. And I'm more than happy to share any resource I have on it, like our syllabi and anything that we have, because I think it's pretty easy to build. If you're lucky, you'll get, depending on how things are set up for your department and with your College of Medicine, you may be able to benefit from some of those FTAR returns on the tuition that the students pay to take the course. And so for our program, we actually use that to provide a research budget for our program. Did that answer your question? Okay. Yeah.
I have a related question. How do you get having undergraduates enroll patients in studies through your IRB?
Yes, that's a very great question. So initially, we just did, and then they found out. And they were like, you should stop doing that. And it created kind of a rocky relationship for a little while. So now we have an agreement. So we can show their training. They've reviewed all of our syllabus, they've checked it out, they feel good about what we're offering. They can screen for all of our protocols. They can only enroll for minimal risk. And so the way it works is we have kind of a 2-tiered system. And so if it's minimal risk, they'll go in, we're talking about like basic survey information sheet, they'll do it, they feel really excited about it. If it's something more elaborate, so I have a research study I'm PI for, and we enroll patients into either a methadone or buprenorphine pathway. They can't do that. And so that's when they then page their research chief who's on shift, who works with them to get in touch with a research coordinator who are paid staff, who are trained, but they still go into the room for that for the most part, unless it's like a awkward situation or it's not appropriate. We don't want a gaggle of like 10 students going into it, but they go in, they still get to observe it, they still get to be part of it, they get to make photocopies, it's very exciting. And so they're still engaged with it, but yeah, they're not enrolling for anything above minimal risk.
So for our faculty who are somewhat interested in research, they're not the passionate people who are going to continue to do research, but sort of some of our academic faculty are sort of in the mid-range where they're not like super scared or hate research, but are sort of there. When the ACGME requirements changed as for PubMed IDs, I noticed a lot of decreased productivity from those people because it was no longer a requirement from the ACGME program. Have you had any successes in trying to keep those people motivated outside of maintaining department requirements for PubMed IDs?
I think it's a great question, but it speaks to the underlying issue, which is people were doing it because it was the stick. right? We were focusing on the care versus stick, and we're saying, you have to do it, and you're required to do it. And what that tends to create is a lot of minimal publishable quality, like articles that would just get out there enough to get you a PubMed ID. So you had to aim for like the lowest common denominator of that, and you had a PubMed ID, and HEG didn't really care beyond that, right? They're like, let's run our totals, okay, let's check it, it's real, good. And then we just shifted it over, and I don't know that we made a big impact with that anyways, because they weren't doing the stuff that was actually gonna be impactful, meaningful, or for a lot of them, probably wasn't gonna be that like meaningful to them as a person, because they were doing it for a checklist. I would challenge that whether or not we had that requirement, the focus is on the carrot. What's the drive? Some of it's going to be some extrinsic motivation, like if we can incentivize them, you could put in education value units, you can emphasize that, you want to have a top-down mission, but I think the bigger thing is building an intrinsic motivation. Find the thing that they drive, that drives them, that gets them really excited, and then parlay the research into that. Find the person who's like, oh yeah, like, I think Roz was saying an example of someone who was having like really like a frustrating scenario. Or no, actually, it was Kiran. You were saying about someone in your faculty was like having a scenario like, why don't we turn this into a chart review? Like find the thing that impassions them, that drives them, that they care about, and convert that into research. You're gonna have people doing it, and then they're gonna actually want to do it. So I don't really see the HGME. I think it actually freed us because it took us away from having to focus on a quantity issue that was not very good quality, and gave us the freedom to say, you know what, fine, one person can crank out some papers, everyone else can actually focus on the thing that's going to be meaningful, impactful, and useful.
And I think that's all the time we have. Thank you so much for coming. I think if anyone has any other questions, we'll be around if you want to come up and ask them. So thank you.